So we continue then next, and we will get an overview from two institutions. What kind of pediatric patients are commonly referred to external beam radiotherapy? The first part is presented by Capizzello Antonio, and the second part by Eftychia Ta.
Okay. Good evening. I am Antonio Capizzello, professor at Aristotle University Thessaloniki, radiation therapy oncology. Clinical profile and outcome of a pediatric oncology patient treated in my department only. And after is Eftychia Ta, resident of the Cancer Hospital Traigenio, Radiation Oncology Department Thessaloniki. She speaks about pediatric patients commonly referred for external beam radiotherapy, covered in part from you. Radiotherapy plays an important role in the multimodal treatment of the children cancer. The aim of this presentation is to provide an analysis of pediatric oncology patients treated with radiotherapy in my institute at Cape University Hospital Thessaloniki. Is a retrospective chart review of children treated with radiotherapy between 2010 January and July 2024. Is the same period so we have a new department. The patients very late down for me. Over 120 patients who were identified, 101 formed the base of this presentation. And all number you can see is relative in the percentile, because it's a sense 100 patients. Some of them have continued their oncology treatment in different institutions, so we do not process this data. 9 of these 9 patients did not finish the started treatment because of the worsening of their general condition, or because they decided to continue their treatment abroad. The vast majority of patients were previously diagnosed by histological examination, except some patients with brain tumor who were diagnosed by MRI examination only. And the patient underwent chemotherapy at the pediatric hematology oncology clinics of the 2 hospitals of Thessaloniki. All of these 2 institutions are regional reference centers of North Greece for the treatment of children with cancer. From 2010, 3D conformal radiotherapy technique was introduced in our institute. In the analysis period, patients must were treated with the 3D conformal radiotherapy and the remote technique after 2016 and the IGRT. The relation of the therapy volume and the organ at risk precision of the total dose and dose constraints were in accordance with the international treatment protocol used at the time. It's umbrella, etc. Radiotherapy was delivered according to the International Commission of Radiation Units and the measurement ICRO recommendation. Variables collected from the patient medical record were demographic characteristics, age and gender, tumor characteristics, such as histopathology, tumor site, and radiotherapy treatment. The patients were grouped according to age into group 0 to 14 and up 14. Tumor type, according to tumor type, we have 9 groups. CN, central nervous system tumors, lymphomas, leukemias, leukemia, neuroblastoma, nephroblastoma, bone sarcoma, soft tissue sarcoma. Even the treatment in composed full group, prophylactic, definitive, adjuvant, palliative. Radiotherapy treatment site in non-group, cranial, abdomen, and etc. Radiotherapy treatment, the total dose delivered. This is the patients who have treated between the is 2010, 2024. Is homogeneous, is 5 years. One group 5 years. One group 5 years is the percentage is same. Age group, we're supposed to age group. Yep. Sex, male is the same, little percent, 28% is 28 patients male, and the female 40. Is a the years to 14 years is 78 patients, 78%, and 23 is up 14 years. Here is the status alive died. So respect free recurrence and metastasis. Alive in 14 years is total 51%. Is for with the recurrence, but it's alive. There are this was lymphoma principal, and died 27%. Total 78%. For up 15 years, the status was 16 and 7 died. The total 67 and died was 54. This is the histopathology percent. 32% is leukemias, and the lymphoma, and 28% lymphoma. The central nervous system and medulloblastoma is the same lymphoma, 20%. Soft tissue sarcoma is 8% patients. Bone sarcoma is 8%. 9% is nephroblastoma, WHIMS. Here is the by histology, alive and died, the status of my patients. Life is total 67%, and died 54%. But you know that the leukemia is 27%, and lymphoma is 17%. Lymphoma and leukemia is half of patient alive. Other tumors, central nervous system, life is very bad. 3 patients died 10. And then medulloblastoma from 5 alive who died. The other is normal. The age from 1 year, each year, is patients who with the anesthesia. Total was 22 persons, 22 children. leukemia is the first with 11%. And this is the years 1, 2, 3, 4, 5, 6 years, and the number. Follow status recurrence with the surgery, radical surgery, and it was larger with the surgery, radical 14 patients. No surgery, 27, subtotal 4, and biopsy 18. This is alive. 63 total. Recurrence 28. Metastasis 6%, and we can see the results. Histology and site of the radiotherapy. Lymphoma, cranium, and leukemia, cranium is very big. Okay. Radiotherapy treatment, total dose. You can see it's normal for our radiotherapy. This is the dose, and the patients who have this treatment. Very low dose is 818. I will only 2 minutes, okay? And the low dose radiotherapy, this is the patients, 20 patients. The minimal dose radiotherapy was 70 patients, and the high dose rate was 27 patients. This total, this and the finish is 3D conformal radiotherapy. The one patient we treated in my department is the last patient I made was 2019. Thank you, Mr. Tadeo.
Thank you very much. Then we continue with the second part of the talk, Eftychia Ta with patients referred for external proton therapy.
Good afternoon, everyone. As I see, my professor wanted to talk a lot. So I will just add some details that we haven't heard before. Okay. Ωραία. All right, so here is an overview of the key topics we will be covering today. This pie chart illustrates the distribution of the most common pediatric cancers. As we can see, leukemia accounts for the largest portion, making up 30% of pediatric cancers, and then 25% the CNS tumors, and so on. Every 3 minutes, a child is diagnosed with cancer globally. In the US, 1 in 285 children will be diagnosed before the age of 20, with 15,400 new cases annually. Survival rates exceed 80% in high-income countries, but remain below 30% in lower-income regions. EBRT is crucial for managing pediatric brain tumors, lymphomas, and Wilms tumors. Precision techniques improve the survival and quality of life. Challenges include effective immobilization anesthesia needs, especially for the CNS tumors where the precise targeting is essential. This graph from St. Jude Children's Research Hospital illustrates the dramatic improvements in cure rates for various pediatric cancers between 1962 and 2003. These improvements are largely attributed to advancements in treatment modalities, including chemosurgery and radiotherapy, as well as supportive care and earlier diagnosis. For example, Ewing sarcoma and Hodgkin disease, cure rates have seen a dramatic rise to 55% and 90% respectively, largely due to effective multimodal treatments that include radiotherapy for local control and chemotherapy. Okay. Medulloblastoma and this tumor. Both have seen significant advancements, with cure rates now approaching 75% for medulloblastoma and 90% for Wilms tumor. And about retinoblastoma and rhabdomyosarcoma, radiotherapy alongside surgery and chemo has been instrumental in improving cure rates for retinoblastoma, reaching 95% and rhabdomyosarcoma now at 75%. Here are some common indications that we have already said, so I'm going to skip it. So let's take a closer look for medulloblastoma. It's one of the most common pediatric brain tumors, requires a multimodal treatment approach, and post-surgery radiation therapy is standard to prevent recurrence. Let's break down the key aspects of medulloblastoma radiation therapy. So there is standard risk and high risk. We use craniospinal irradiation. It's the standard treatment for medulloblastoma to address any potential microscopic spread of the tumor. The standard risk patients receive 23.4 gray to the entire craniospinal axis, delivering in 1.8 gray fractions, while in the high-risk patients, we use 36 to 39.6 gray, depending on the race and risk factors. Additionally, we add a boost to the posterior fossa. After CSI, patients receive this boost. In the standard risk patients, a dose of 54 to 55.8 gray is typically given, while in the high risk, the same dose is applied, but in high risk patients, it may extend to areas with residual disease or even metastasis sites. Also, about the timing, it starts within 4 to 6 weeks after surgery, depending on the patient's recovery. For children younger than 3 years old, radiation therapy is often delayed due to concerns about neurocognitive side effects. So, here is the boost to the fossa. It's a 54 to 55.8 gray, tailored to the patient's risk profile for optimal control. IMRT significantly reduces the cochlear dose compared to the 3D conformal RT, lowering the ototoxicity risk. On the left, we see the dose distribution with 3D CRT, where radiation is more uniformly delivered across the entire plant target volume. However, this approach exposes nearby critical structures such as the right and left cochlea and the optic chiasm to higher doses, which can lead to increased side effects such as the hearing loss that we mentioned or vision problems. On the right, we see the distribution with dynamic IMRT. With this technique, the radiation dose is more precisely modulated, delivering a higher dose to the tumor, while significantly sparing the cochlea and optic chiasm. Here also we can see it in this axial view, the comparison of these two techniques. So as we understand, 3D conformal RT poses a 64% risk, while IMRT reduces this to 13% by optimizing dose distribution. This pie chart provides an overview of pediatric malignant bone tumors based on the histological classification from a cohort of 664 patients. Affecting children aged 5 to 25, Ewing sarcoma often involves long bones with 25% presenting metastatic disease. In the treatment of Ewing sarcoma, radiotherapy plays a critical role in managing both unresectable tumors and residual disease after surgery, as well as in cases with metastatic spread. The primary objective of radiotherapy is to achieve local tumor control while minimizing damage to the surrounding healthy tissue. This is especially important in pediatric patients where reducing long-term side effects is a priority. Typically, radiation dose ranges from 45 to 55 gray, carefully balancing effective control of the tumor with minimizing toxicity to the healthy tissues. One of the major challenges in treating Ewing sarcoma with radiotherapy is the potential for growth disturbances and underlaid effects, particularly in children. This can affect the bones and surrounding tissue, leading to long-term complications. This pie chart provides a breakdown of the various histological subtypes of soft tissue sarcomas, a diverse group of malignant tumors that arise in tissues such as muscle, fat, and blood vessels. Radiotherapy is a key component in the treatment of rhabdomyosarcoma, particularly in cases where complete surgical resection is not feasible or when residual disease remains after surgery. It's also indicated for high-risk patients to ensure local control of the tumor. Radiation is used in situations where the tumor cannot be fully resected, for residual disease, or for the patients with high-risk features. The typical dose ranges from 36 to 50.4 gray, depending on factors such as the tumor size, and resection status. The timing of radiotherapy generally starts around 12 weeks after chemo, allowing for recovery and chemotherapy to address systemic disease. If there's residual tumor post-surgery, or if a complete resection wasn't possible, a boost dose of 41.4 to 50.4 gray is in total delivered to ensure local control. Radiation therapy plays a crucial role in treatment of Hodgkin and non-Hodgkin lymphoma as well. It targets residual tumor after chemo to shrink bulky disease. There are low and high-risk patients. About non-Hodgkin, doses are 24 to 30 gray, especially for CNS involvement, to manage residual disease. About Wilms tumor, radiation doses of 10.8 to 20 gray start post-surgery with boosts for residual or high-risk cases. Leukemias. Radiotherapy is used selectively for CNS prophylaxis with doses from 12 to 18 gray combined with chemo. One of the most effective ways to reduce the risk of long-term complications from radiation therapy is by lowering the total dose and reducing the field size of radiation. Here are two examples. The mantle radiation therapy for Hodgkin disease. Historically, mantle RT for Hodgkin disease involved doses up to 44 gray. By reducing the dose to 20 gray and shrinking the field size, we can still achieve excellent survival rates while sparing the thyroid and reducing the risk of primary hypothyroidism. For pediatric patients with acute lymphoblastic leukemia or medulloblastoma, reducing the dose of prophylactic cranial radiation to 18 gray helps to spare growth hormone dysfunction. This is especially important in young children where preserving normal growth and development is a priority. Despite the lower dose, this reduction does not compromise survival outcomes, but significantly decreases the risk of late effects such as growth hormone deficiency. This slide illustrates the significant reduction in radiation dose and field size in the treatment of Hodgkin lymphoma over the decades. One of the most effective ways to protect sensitive glands during radiation therapy is through total or partial shielding. This technique helps spare the glands at risk for excessive radiation exposure, reducing the likelihood of long-term dysfunction. When treating head and neck tumors, radiation doses to the neck can be quite high, typically in the range of 50 to 70 gray. Without proper shielding, this can lead to primary hypothyroidism due to radiation damage to the thyroid, pituitary dysfunction if the pituitary gland is within the radiation field. Shielding the testicles during radiation therapy for pelvic tumors is critical for preserving reproductive and hormonal function. A dose below 3 gray is generally sufficient to spare fertility, ensuring that the patient retains the ability to have children in the future. A dose below 20 gray is necessary to spare Leydig cell function, which is essential for maintaining normal testosterone levels and sexual function. However, with partial shielding of the thyroid gland, here we can see the importance of minimizing radiation exposure to the thyroid when treating head and neck tumors to reduce the risk of dysfunction of the thyroid. However, that's what I wanted to say. No matter how advanced or precise the radiation therapy technology is, if the organs at risk are not adequately delineated, the entire process can result in unnecessary damage to the healthy tissues. While 3D conformal radiation therapy has significantly improved the precision of radiotherapy, further optimization is possible with newer technologies that offer even better dose distribution. For example, IMRT allows for precise modulation of intensity of the radiation beams with each treatment field. The result is in even more accurate targeting of the tumor, delivering higher doses directly to the cancer while sparing adjacent normal tissues. Proton therapy also represents even as the most advanced approach. Protons have a unique physical property called the black peak effect, which allows for precise deposition of the radiation dose at the tumor site. This slide compares the quality of life and survivors of CNS tumors who underwent radiation therapy versus those who did not receive radiation, focusing on three key outcomes: never employed, emotional problems, and fair or poor health. So, as you can see here, among survivors who received radiation therapy, 21% were never employed, with an odd ratio of 16, indicating a significantly higher likelihood of unemployment compared to those who did not receive RT. This suggests that radiation therapy can impact cognitive or functional abilities, making it more challenging for survivors to engage in employment. Strokes occur in about 16% of cases, often years post-treatment, highlighting the importance of long-term monitoring. The risk of secondary cancers remain high, with conditions like Hodgkin disease showing elevated ratios post-radiotherapy. Models predict second cancer risk based on organ-specific doses and lethality, refining treatment plans for better outcomes. This slide presents data on the estimated absolutely yearly rate of developing a second cancer in patients treated for rhabdomyosarcoma, comparing various radiation modalities. The yearly rate of developing a second cancer with X-ray therapy is 0.06%. This is considered the baseline risk with a relative risk of 1. IMRT reduces the yearly risk slightly to 0.05%. with relative risk of 0.8. This reduction is due to the better targeting and dose modulation, which spares surrounding healthy tissues from excessive radiation exposure, while proton therapy offers a further reduction in secondary cancer risk, with a yearly rate of 0.04% and a relative risk of 0.7. In patients treated for medulloblastoma, as we can see here, for esophagus and stomach, the yearly risk of second cancer is highest with X-rays, 0.15%, slightly reduced with IMRT, 0.11%, and eliminated with proton therapy. The overall yearly risk of developing a second cancer is 0.75% with X-rays, 0.43% with IMRT, and significantly lower at 0.05% with proton therapy. Proton therapy reduces second cancer risk significantly, demonstrating its value in pediatric cancer treatment. Lowering the second cancer risk reduces overall treatment costs, reinforcing the need for advanced technology investments. In conclusion, external beam radiotherapy remains crucial in pediatric oncology, with continued technological improvements offering better outcomes and quality of life for young patients. Thank you for your attention.
Thank you very much for your talk and giving us the overview not only of the indication for radiotherapy and not only the doses needed to treat those indications, but especially also the dose constraints, and clearly showing that the lower the doses, the less is the risk for relevant side effects. And what I especially liked is also the organs at risk, because given the algorithms, the artificial intelligence algorithms, we need to make a benefit out of it. We get all the contours basically by just one click, and it helps us visualizing what we should spare. Thank you very much. It was the perfect preparation for the next talk.
Just one more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.